everybody. This again is our first learning quality improvement session for the HPV project, and I'm glad that many of you have joined us since this is one area where I think we can make a difference in the rates of vaccination for these children. I will provide the introductions about the group that works here at the OhioP, as well as those of us who are participating in the project. And then Sam will actually go through the KETA and the data collection. And then Dr. Feemster will actually have a presentation on the HPV vaccine. So next slide. The next slide, I believe, says the fact that we want to allow you to have time for questions at the end of each section. We just caution you to please mute your phone by dialing 4*. Is that correct, Melanie? Or is it *4? Okay. But don't put your call on hold, because then we often hear your background music. And again, you can interrupt any time if you do have questions. Next slide. Team introductions, and I think I kind of went over this slide a little bit earlier, but you can see the names listed there. So I will provide the introductions. Sam Ansel will actually go through the data collection in the KETA system. Michele Dritz, I did forget earlier, I apologize, Michele, since you've worked harder on this than I have, will update the HPV recommendations, and then vaccines will be covered by Kristen Feemster. Next slide. So again, this is myself, Jill Fitch. I am at Nationwide Children's Hospital, and I practice in pediatric and cardiac ICU care. I'm also current treasurer of the Ohio AAP and director. Michele, as you saw a little preview next, is coming up. Dritz really has been instrumental in helping us develop this program as well, and she's the primary care consultant for our HPV program, and is the medical director for the TALK program, which some of you may have been involved in or heard of before. Next become the glamour shots of our Ohio AAP office. Sam Ansel is our PhD, who provides us with input on the quality improvement and data collection of our products and analysis of the data. And again, she does this for many programs. She's phenomenal because she actually does a lot of this from her home in Atlanta, or in Georgia. You don't live in Atlanta per se, but.
Sorry, Sam, I forgot to put the number of programs in there. Is it 7 of our QI programs?
Around, yeah, I think so. Lose count.
Mm-hmm. And next is probably the most important person on the team, Melanie Farkas, who really I owe a debt of gratitude to, because she has been great at contacting the practices that have agreed to join us and working to put together this presentation as well. She's our Director of Communications and Immunizations, and she's project manager for MOBI, TIES, HPV, and the MENB2, which is coming out as well. So she really is an expert in immunizations. Again, I'm going to go through the different practices, but if you can provide us with a little bit about your practice, why you have decided that this is a valuable MOC Type 4 project for you, and that may be because you feel that your immunization rates are not where they need to be, or it may be that you're coming due for your renewal and need your MOC Type 4, and how do you currently monitor and intend to monitor the HPV population, and how to get these children vaccinated.
So right now we don't have one on the phone from Grant Family Practice Southwest Grove City. As I mentioned, they ended up having a staff meeting that is running over, and they should be joining us hopefully in the next 20 minutes. And then the same with Grant Family Practice East in Columbus. So we will go then to Contemporary Pediatrics in Centerville. We have Delilah on the phone with us. Unfortunately, Nancy was not able to join us because of a family emergency. So Delilah, do you want to just kind of introduce yourself and and the practice that you were at, and I know that it was Nancy who kind of spearheaded signing up for this project, but can you talk a little bit about why it's important at the practice to increase your rates?
Sure. Good morning. My name is Delilah. I am the care coordinator at Contemporary Pediatrics. I am an RN, and we have been struggling. I've only been in the position for about a year and a half. Prior to me coming, we were struggling with getting the kiddos in for second and third vaccines. Now our numbers are starting to increase a little bit by some things that I've done. I run quarterly reports of who needs the second and third vaccine, and I kind of stalk the parents to get them to come in. Still having a little bit of struggles, but the rate has gone up. I think it went from 15% up to 29% the last time we ran reports. That could be completely wrong, but I feel it for some reason those numbers are in my head. Again, this is Nancy's thing, so I apologize. But we just need a way to get the patients in, especially for those second and third vaccines. Dr. Myers has a wonderful rate with his infants as far as getting them vaccinated. I think he's at like 97% or something, but we really struggle with the Gardasil and the Menactra with the older children.
Thank you.
Wonderful. Delilah, thank you very much for joining us today, especially kind of at the last minute taking the reins.
Okay.
Welcome to the program.
Thank you.
And next we have Mercy Health, Lorraine Pediatrics. Dr. Akbar is an Ohio AAP member and was at our annual meeting. From his practice, we have Mindy on the phone. Mindy, do you want to introduce yourself?
Hi, yeah. So my name is Mindy Felder. I am a CMA, but I'm also the office coordinator. Dr. Akbar is actually in the process of getting ready to take his boards, so he is trying to get on as many projects as he can get on. But vaccines is one of the most important things in our office because we are in a very poor economic location. So getting parents to bring their children in to be seen, not only for well exams but sick visits and whatnot, and getting as many missed opportunity chances to get their immunizations is very high on his list of things to do. And then with the teens, making sure that they're getting all the important vaccinations is another priority. So having the parents know the information about the vaccines and what they prevent is very important to us in trying to make sure that they know that these vaccines are available to them and can help prevent major diseases is high on his list.
That's great. Thank you very much, Mindy, and welcome to the program. So next, I'm going to make you the presenter, Dr. Ansels.
Okay.
And Sam, I think we're having a hard time hearing you, so I'm not sure if you can turn the volume up on your phone, maybe.
Can you hear me okay now?
A little louder if it's possible.
I'm speaking right into the phone, so I might have to call in and change on different phones if it's still not a good volume.
And Melanie, the slides just disappeared.
Yes, so I have to show my screen. I have, let's put this in presentation. Okay. All right, and can you guys see the laying the foundation slide?
Yes, now that it's back up.
Okay, and can you hear me okay, Jill, or do I need to change phones?
I can hear you okay.
Okay. All right, let me grab the other phone just in case there's issues. But for today, I'm going to be talking a bit about some of our foundational quality improvement methodology that we'll be using, and then also explaining some of the information that we have for the KEDA, which is our Quality Improvement Data Aggregator System, and how we'll be utilizing that as our landing page as well as our data entry resource for the collaborative. I do want to preface that we have some updated HPV recommendations, and Dr. Dritz will be speaking on those. So some of our data is in the works. We had the recommendations come down to us last week, and we've been updating the system. And I don't know why the slides are changing by themselves. Updated the system so that it reflects those, and we can be abreast of all the new information. So as soon as it's ready to go, we will have the system open for you, but I'm going to give you kind of a background on how all of that information will be gathered and how you can access the system just to familiarize it. And then if we need an extra call, I'm happy to do a technical assistance and walkthrough of KEDA to fill in any of the gaps that we weren't able to cover and address specifically today because it's in the works. So with a lot of our quality improvement collaboratives, and for today, really emphasizing the importance of having our core quality improvement team come together and collectively work as we approach improving our HPV initiation rates, and then looking to understand what we're trying to accomplish over the course of this collaborative and some of the pre-work items that will help you prepare, and then the next steps that you can do after today's learning session. So what I always like to do is start off with what our project goal is. And for this specifically, we're looking for all 11 and 12-year-olds to initiate the HPV vaccine series. And that, of course, doesn't exclude the older adolescents that you may see, but really trying to get on that schedule and that recommendation series that we have, and getting these adolescents started early, and then, of course, working with our older adolescents to initiate and complete the series with them as well. And to kind of bring everything together on a roadmap, we have our key driver diagram, and you can really see this as your resource throughout the collaborative that not only hones what we're trying to accomplish, but puts key elements, our key drivers, into place of what we feel are key elements that will help you move and get to that global aim of having all of your 11 to 12-year-olds initiate the HPV vaccine series. And then a series of interventions that are listed on the right-hand side that show you some stepping points that you can use to kind of get started if you're trying to really improve this process from grassroots up, or maybe some things that you can fine-tune to move that needle additional room and momentum to get towards the aims that we have set out. And while we have the global aim and the world peace aim of getting all our 11 to 12-year-olds initiated with the HPV series and getting that going, we also have some other aims that we're hoping to accomplish through the course of this collaborative, which runs several months, and what we know are stretchable but achievable goals, and that's to increase your HPV series initiation rates by 10% from what we start at baseline, and then working so that we all are agreeing that we strongly recommend our HPV vaccine series to 11 and 12-year-old male and females, and that you feel confident in how you can address parental concerns and any issues around hesitancy or refusal. So really equipping you and building that toolkit of resources that you have to help with this immunization series. And while the key driver diagram really provides us a very specific roadmap to what we're trying to accomplish, the graphic here on the bottom of this screen gives you an overview of how we're going to walk through the collaborative over the next couple of months. So here we are in the pre-work period. We're really laying the foundation of some of our quality improvement methodology and then some of the fundamental knowledge that we'll use around HPV series to move forward into our action period. And this kind of is a hybrid model of what we normally do with the Ohio chapter's learning collaboratives, where we traditionally do an Institute for Healthcare Improvements learning collaborative series with an in-person kickoff meeting, and then we host a series of in-person action period calls, similar to what we're doing today, as we progress through each month of the collaborative. For this collaborative that we're working on, it'll be a hybrid of that. So we will have some in-person touch bases. We have today with our kickoff learning session, and then every other month we'll have a live touch base with you through our action period phone calls, which will be a conference call and a webinar like this. The other months will be recorded sessions, and you'll find that information on how you can access that, and I'll show it to you, which will be housed in KEDA. But for today, we're discussing our pre-work, we have our learning session, and then we'll start to collect our baseline data and kind of get on the same playing field with all those practices that are involved to see where we stand as a group with our HPV rates. And then we can move into the action period to start collecting our data, enhance our work around initiating this series and working on the new recommendations by testing changes using rapid cycle improvements and plan, do, study, act cycles, and having bidirectional feedback between us on the HPV project team and then you as practices about what's working, what's not working, and how we can help you with that process. And then we like to wrap everything up with sustainable best practices and what you can do to keep things moving forward. So in terms of this, we're really looking at first starting off on the right foot with a good improvement team. So hopefully with the teams that you guys have shown on your introductory slides, we know who those individuals are, but maybe after today you might have other people in your mind that you think would be helpful to include. So just taking some time to identify those people that will help you with this process, with testing changes, with learning about how to best integrate some of these best practices into your clinical setting, but also how to do that for a longitudinal time period. And including a variety of team members from your front staff who may be helpful with reminder recall processes, your nursing staff that's assisting with immunization, and other providers that would be helping with the discussions that you have about why we should be doing this this immunization and why it's important to do this series. And of course, having a champion, it can or cannot be, it may or may not be a physician, but we find that those are good to have a physician leader. And then with this, some sort of technical expertise, not only around immunizations, but also with reminder recalls, your EMR, and how we can use all the different resources that you have at your hand to really support this initiative. And some key elements, this just kind of re-emphasizes what I had just addressed on the previous slide, but having a leader who knows what the changes are and has maybe identified some barriers that may arise and coming to help address those and being the spearhead and champion for this. And then, of course, your clinical and technical expertise, but also someone that Melanie can have day-to-day contact with, not necessarily day-to-day, but someone that we can touch base with, send reminders to, follow up on items if need be, just so that we have that point of contact with you. And then just a few items about sustainability and how we can approach this from the get-go to build some of these key evidence and practices that have been identified in the literature that help in quality improvement projects stay for the long haul. And I mentioned that we do sustainability at the end, but I like to layer in some of it as we get going so that it's at the forefront of your mind. And I think one of the key features for sustainability are the people that are working on this, letting us know and then your practice know who's really engaged and vested in this program. And then really understanding where everyone's coming from. We know, this is an extra thing that you guys are doing, and understanding all the different components that kind of tie into the extra work to improve this specific component within your clinical setting and what it does in terms of, workload and other challenges that may be faced logistically. So getting people engaged, understanding barriers or burdens that may be faced by those individuals and helping address those as we're working to improve our HPV initiation rates as well. And then to also empower all the individuals on your core QI team, the patients that you're seeing and the providers that you're working with, listening and responding to all those individuals because they really do help drive the improvement process if people feel that they own this and that you've created a culture within your practice that all voices are heard, there aren't any bad ideas, we can all work to improve components of this and have different sets of views and experiences that we bring to the table that can really help drive this improvement project. So engaging individuals from the start and letting them own the process and feeling that they have a sense of input in this is really instrumental for keeping this going, but also for getting it started and then moving it forward in the future. So those are just two of the sustainability items that I think are important to have from the start, and you'll see some of those other ones as we move through the collaborative together over the coming months. So while I provided the key driver diagram, which is our very specific roadmap to changes that you can make that impact key drivers that move our needle to the direction that we're trying to head, we use the model for improvement as our theoretical framework to drive our improvement process. So we like to hone our vision of what we're trying to accomplish, and we have one from the HPV project team, but you as a practice may have additional layers that you would like to achieve or maybe even stretch further than the goals that we have set. So those aims that we have as a project team are listed on that key driver diagram, and I touched on those at the beginning with initiating our increasing our initiation rates by 10%. You may feel that that's too small and you can get to 20%. That's great. So I think coming together and looking at what we're trying to accomplish as a collaborative and seeing how that fits with what you think you can do as a practice to stretch yourselves but also make it an achievable goal. So looking at this and coming together as your team and determining what your landing point and outcome you would like to be is one of those great first steps to take once you've brought all the key players to the table. The next item or question that we address within the model for improvement is how will we know that change is an improvement? And we need to have something that we're evaluating against. And again, those aims that we've mentioned in the key driver diagram are the standards that against which we're going to measure and help us learn. And this ties into another sustainability factor, but measurement in general, with the purpose to help us learn, to build incrementally, and kind of through an iterative process to know from foundational what we're doing, take lessons learned, characterize and define gaps for improvement, and start to close those, but also have a conversation between what we're seeing in the data amongst yourself as a practice and with us as the project team when we have our live calls to figure out what the data is telling us and how we can use that to determine the effect of the improvements that we're making, what additional things we may need to do, and evaluate the progress that we're making collectively towards our collaborative goal and the goal that you've set as a practice. And it's not just numbers. So when we move forward and do test of change, we have experiences that we learn about how qualitatively things may work. So as you're doing tests of change, you may not have specific numbers that come back, but you have experiences or anecdotal information that can help inform your next steps. So keeping that in mind, too, then that's another way that we can characterize and learn through the improvement process. Normally at this point, we have data to present and kind of show where we are at baseline and where we would like to go. We're going to be talking about what data you're collecting and then putting that into KEDA and then defining that gap that we would like to close. But I did want to bring some of the responses from the pre-work surveys that individuals from each of the practices have completed. And if you missed out on that or your provider didn't do it, it's not done. You can still go ahead and complete that, and then we have a little more information about what we're trying to help you work on. But I did want to share what I gleaned from those. So from the people that had completed the survey, all had stated that this was their first quality improvement collaborative. So if you have any questions at any point about how things work or terminology, feel free to stop. It's a very informal learning process, and we're here to kind of help through any questions that you have. And you have Melanie that you can always reach out to, and she can vet you to any person on our project team to answer any questions you may have. The next thing was looking at a series of statements that we had posed to individuals that completed the survey, and this was looking at your beliefs about some of the recommendations and just what the HPV vaccine does or does not do. And everyone either agreed or strongly agreed that the CDC's recommendation for HPV vaccine for males and females, you agreed with that for having that started at 11 to 12 years of age, that you thought it's safe, effective, and beneficial to your patients. It's a cancer prevention tool. It is beneficial for cancer prevention in males as it is for females, and that it's an STI protection tool. You also believe that the immune response to the HPV vaccine is more robust in those younger patients, which really fits well with the goal that we're trying to accomplish, and then the belief that HPV infections have medical consequences for my adolescent and young adult patients, both now and into adulthood. So kind of seeing that we're collectively on the same page with a lot of our beliefs and moving forward, we can use that to build on some of the lessons that we'll be learning. Some of the practices or behaviors that you guys are currently doing all either agreed or strongly agreed that you provide a strong recommendation for the HPV vaccine to both your male and female 11 through 12-year-olds. If they haven't already received the HPV vaccine, those older adolescents, 13 and above, you do strongly recommend that HPV vaccine to both male and females, and that you discuss getting this vaccine at any visit with an adolescent, be it an adolescent well visit or any other type. You are addressing this recommendation with your adolescent populations. And then you discuss this vaccine as an option that's available to families if they choose, rather than a recommendation that includes other CDC-recommended adolescent vaccines like MCV4 or Tdap. And then you strongly disagree that you wait until a patient is sexually active before you actually recommend the HPV vaccine. Some behaviors, some kind of practices that are currently or may not be in place, the identification of adolescents who are due for their HPV vaccine, as well as those are due for the follow-up series in the doses, were areas that seemed practices had interest or would like to get processes in place to help identify those adolescents to initiate the series on or have them come back for completing the series. So hopefully that's one of the gaps that we can help you close with some of the information that we'll be presenting to you and as we work on over the course of the collaborative. And then finally, parent reactions. So your perception about some parent reactions or their response or reasons for vaccine hesitancy. So you agree or strongly agree that the request to delay the HPV vaccine until a further visit is one of the reasons or reactions of a parent for the series, and that sometimes parents appear offended or angry when you bring up this topic. And then disagree or strongly disagree that they accept the recommendation for HPV vaccine without any questions, and that they express concerns about the HPV vaccination. And then the final thing was your kind of response when families are hesitant about receiving the vaccine, that you offer reassurance that it's safe, that you have materials like the VIS sheets to provide to them, that you tell parents that you have vaccinated or would vaccinate your own child, and the strongly urging parents to initiate the HPV series at the present time. So you have the proper response in place for any of those hesitant parents and are equipped with those resources to help address that. And then the final thing before I get into some of the pre-work and the data collection system is your perception of why parents are hesitant. And I ordered them from ones that all of you had said were reasons for hesitancy down to the least likely reason for hesitancy. And it ranged from having concerns about the vaccine in general, discomfort about talking about sex with their child, long-term complications, or that the child was sick at the visit. But knowing these can help us and then you as providers see collectively what are some of the barriers we have for those parents that are hesitant. And then very similar to the last slide, your response to that hesitancy, 100% of the time, those same items that I had just covered on the previous slide were items that you provided to families when they were hesitant.
And Sam, this is Jill. If I can just interrupt real quick too, and I think focusing on the parental concerns and focusing more on the cancer prevention of the HPV vaccine is one of the ways that we can have a stronger provider recommendation, since we don't have any other vaccines which are so effective with cancer prevention.
Yes, I think that's a good point. Any comments from the providers or clinicians in the audience? Okay. So pre-work. This is what's going to kind of help all of us come together and understand where we currently are with our HPV initiation and completion, and then other data surrounding that. So data has shifted a little bit from what you may have seen in the pre-work packet that Melanie provided. So I'm going to run through it here, and it'll also be updated on the KETA homepage, which you will all have access to if you had provided Melanie with the provider that will be using the system. So data will be, for baseline, we have 3 cycles, and each cycle consists of 15 charts, with the goal to pull them at random from each of the months that we have listed here. And we do a 3-month baseline just so we have kind of a picture of what your practices look like around the series. And pulling from the charts of August, September, and October, 15 charts each. And then if you have multiple providers that are in the practice, kind of stratifying that 15-chart pull amongst those providers so it's good representation of all the different clinicians that we have. And once you pull that data and review the charts, we can enter that on the project homepage within KETA. And I'll walk through that process and go to the site in just a moment. The other elements of pre-work are the pre-work survey, which is some of the information that I just provided. Again, if someone hasn't had a chance to do that, it hasn't closed, so you can go through and complete that. That is a component of the MOC Part 4 for those providers that are seeking their quality improvement credit. And then we have our practice agreement just to see where everyone is in agreement on the MOC Part 4 collaborative requirements and the items that are due there. And then the final piece, if you aren't familiar, and since this is many of your first quality improvement collaborative, there's a quality improvement webinar on the KETA page that provides information about a little more in-depth quality improvement methodology and how we use that throughout our learning collaborative. So that's available for you to watch, familiarize yourself, and kind of get on the same page with those and some of the terminology that we'll be using throughout the collaborative. So the chart review tool. Here is a revised chart review tool that goes with the recommendation that Dr. Dritz will be speaking about shortly. And it has some specific information to collect that will help guide data entry into the system. This part is still under works within KETA. I spoke with KETA this morning to see where they were in the process of updating this, and we're finalizing those details. But what it'll look like for you as you review the charts for each cycle that you'll be entering is to note the date of visit and birth date, as well as the age of the adolescent that attended the visit. And the date of visit and all the dates that are listed on this tool will not be entered into KETA, so you don't have to worry about any identifiable information of the patient that's there. We'll be walking you through how to interpret the differences between the dates to note the measures that we're collecting. But this is just for your reference and to facilitate the data entry process. And then the main component of your chart review will be noting what dose or doses of the HPV vaccine the patient has received. And again, the 3-dose series will be dependent on when the first dose was provided or the timing of the second dose of those individuals that were less than 15 that may have had not enough time between the first and second dose. We also ask just to help guide the process if you had provided an HPV vaccine to the individual today, and of course that would be noted here in the date. And if it wasn't given, we want to understand why. So it may have been that the 2-dose series was completed or a 3-dose series was completed, or that the patient was not eligible. So we want to have it on the forefront and in the radar that patients are eligible or ineligible or completed a series, and then really honing in on the 2-dose and the 3-dose series based upon when that first vaccine was provided to that adolescent. And then, of course, other reasons may be, especially for that first dose, it may have been postponed and what the reason was for that, any contraindications, or if it was refused. So just so we have a good picture of what's happening, and then we know some of the challenges that may be facing you for initiating a series or completing it, and help to address those on the information that we provide during our action period calls. So with the measures, the data that you're collecting, we'll be looking as we move forward to think about what are opportunities for change, and that can be by looking at your data and seeing where gaps are in the goals that we've set and what we want to accomplish and where we currently are, or it could be identifying areas on the intervention side of our key driver diagram, things that you think you need to kind of brush up on or integrate into your clinical flow. There are also opportunities as we progress through the Learning Collaborative to look at your flow around the immunization process, be it recall reminder, identifying patients that need to have the series initiated or completed, and identifying opportunities from that we can work on to improve. And then, of course, the discussions that we have as a team and that you have as a practice to help inform what your next steps are going to be. And that's how we'll move through the rest of the collaborative, with looking at data, thinking of our next steps that we can take, and put those tests of change or steps into place and see what impact we have on our outcomes. So now I'm going to open up the KETA site and get that open for you guys. I have two screens. Can you see the full KETA site, or do you still see a split screen? I'm not sure how that appears.
We can see the HPV KETA site.
Perfect, thank you. So we will provide you with the address for KETA, and it's qi-data.aap.org/Ohio HPV. And Melanie has received the AAP IDs and the email address associated for the providers that are seeking MOC4 credits. We've registered those individuals with the system, and they have access to it currently. If there are other people from the practice that may be entering data on the provider's behalf, just let us know, and we can add you to the system, and then we'll have it ready so you can enter that data for them. With the KETA system, there are two main spots that you're really going to pay attention to. The project homepage is where you're going to focus on your data entry. And you'll see we only have one tool here, and we have a series of cycles. And again, those cycles consist of 15 charts where you'll enter your data. So you'll click and open the HPV chart review tool and enter data here. It'll bring up, and let's see if it's going to work. I'm not sure where she's at in the process. Okay, she might be updating the system. But what it will look like, and it'll mirror the chart review tool that I had showed you with the date of the visit, the HPV vaccines that you provided, and then have a series of questions that go through, was the patient older or younger than 15 when they received their first dose of HPV vaccine? What was the timing between that first and second dose? And it'll walk you through that so you can document the elements that we have on the chart review tool, and then any reasons for why that individual may have not received the vaccine that date, be it ineligible, the series completion, or refusal postponed. The other element that will be kind of our working timeline for the collaborative is in the workspace. So we have the workspace note the items, and this is also in your practice agreement, that are required to get your MOC Part 4 credit. And it starts with our learning session, which we have today, participation in our action period calls, or completing the modules that I'll quickly go through here within KETA. And then the majority of the kind of duty for the MOC Part 4 is completion of your data. So doing your baseline data and then getting data in on a monthly basis. What we have here in each of these sections, and let me just expand it a little, each of these sections here are called modules. So this first module is our pre-work and baseline data collection. So going through and gathering your baseline data and viewing the webinar that we have on quality improvement basics here if that's something that you feel you'd like to brush up on or you need a little more information. And then once you've gone through that information, and this is old information here because we have the new recommendations coming up, there'll be a site or note describing what charts to review, and it'll highlight the information that I had on my PowerPoint slide so you know which elements to review and from what months. The remainder of the site is good to go and doesn't reflect any of the other elements from the old recommendation to the new recommendation. So you can use this as a guide and timeline for what to accomplish in the coming months. After today, it's going to be helpful to go through our documentation of clinical flow and trialing test of change, thinking about your office flow and what you might try as your first test of change to move the needle to get us increasing our initiation rates. And then we have a list of each of our action periods. So, for example, December is our first action period, and it's one that has an online course or recorded webinar. So you'll be able to view the content here. You can do it at any time. It's available. There's no stops. And then you'll enter your data. And we've noted the dates that data are due in each of the modules and the content to view. That's an example of our self-paced. And then we come together in January to talk in person, very similar today, on an action period call, and then you'll enter your data. So it's outlined in that fashion. All the information that you need is here, so it's a one-stop shop for content and our webinars that we'll have, as well as data entry. And we'll talk on a later call once the system is finalized with the new recommendations about how to calculate your data and how you can look at that. So once you close out cycles, you'll have right at your fingertips your data in real time, so you can see how your rates appear on the subset of patients that you've polled. And let me get right back to slides. Any questions on the KETA site?
Hey, this is Melanie. Real quick, I wanted to let everyone know that Nicole Waddle has joined us. I'm sorry. What I
People
say?
do it all the time.
Noelle Waddle, representing two of the other practices. You want to introduce yourself real quick? And we have the other practices just kind of mention where you're at with HPV rates and why you would want to join a project like this.
Yeah. So, again, my name is Noelle Waddle. I am a new nurse clinical manager for Grant Family Practice at the Southwest location and the East Main location. They will eventually have us merged to an office down at Grant Hospital for our residents and our physicians to be closer to the hospital. But I honestly don't know our HPV rates, but I know it's not fantastic just on patients when I always check to make sure things have crossed over from EPIC to Impaxis, and I don't always see that they're getting their HPV. Follow-up's I think pretty good. We'll call and just remind them. But I vaccinated both my kids, so I think anything that we can do to help protect our children is fantastic.
Wonderful. Sorry to interrupt, Sam, if you want to keep going. Thank you, Noelle.
Thanks.
Yes, thanks for introducing, and hopefully those rates will become apparent as we kind of pull together our baseline data and get that into the system and help inform your next steps. And then speaking of next steps, so an action item, I think it's really important to start things off with a team meeting. So that core team that was listed on your slide and any other individuals you think will be instrumental to this process, sitting down and having that first team meeting, get everyone engaged, empower them, know that they own this process, that this is something that, while it is part of, what we need to do as providers, let's be passionate about it, and how can we go kind of above and beyond to work on this initiative. Communicate what you're trying to accomplish and highlight everyone's skills so that you have those in mind, too, as you're moving forward in the improvement effort and can bring those out at particular points. And help further empower those individuals, but utilize everyone's skill set that they have available. And then gather the baseline data. I think with the baseline data and the driver diagram, you'll be able to know what your collaborative and practice-specific aims are and the measures you're trying to accomplish. And then think about any other items you would like to target. Who may be affected by this, be it your patient or provider population, what steps you can take place to achieve this goal and who will be helping with that, and what will you consider improvement. Just kind of having all those items in place to inform next steps as we move forward into KETA's documentation of clinical flow and trialing of your test of change and getting ready for December's action period. where you're going to learn some of the first set of content and have your first set of action data due. So moving forward, hosting that team meeting, really formalizing and putting in concrete wording your aim, pulling together that baseline data, the chart review, and we will let you know when KEDA is up and running, but that tool is available after this call, so if you wanted to get started on it, you can certainly pull that data and have it ready and then enter it in the system as soon as it's available. And then working together as a team through that documentation of clinical flow and trialing of test of change. So it'll give you background on process mapping and office flow, as well as what are some steps you can take in a plan, do, study, act cycle to trial some first steps towards that needle. And then you'll be good to start December's action period and kind of start moving forward through this as we do in our traditional collaboratives. Data is due the 5th of the month, and that's also noted in KEDA in each of the modules. But Melanie will be sending out reminders about data when we have live versus webinar calls and kind of point you to the spot within KEDA or the calls, webinars that we'll be using just to kind of keep everyone on pace with the items that we'll be working on. And with that, Melanie, how do I pass it back over to you, or do you do that?
I will take that control. Hang on a second here.
And this is Jill. I would just like to add, especially for those of you who have not participated in a QI collaborative before, I think you'll find the benefit of listening to other people, knowing that we have the same concerns and problems, and sharing potential solutions to those problems is one of the biggest values, as opposed to, just working within your own practice. That you'll find that listening to what other people say, we're all in the same boat and often can brainstorm together about how to improve the vaccination rates.
So, Melanie, can you just keep control of my slides and I tell you when to hit them? Because there's not very many of them.
Hang on one second here. Okay, I should be good. Go ahead, Dr. Dritz.
Okay. Well, good morning, everyone. Like Sam and Jill mentioned, I'm actually going to give you some hot-off-the-press information that I think in some ways may make our work on improving HPV rates a little easier. And I'm not sure if any of you have heard it so far, but there's been an update in how many doses a patient will need to receive based upon age. So let's go over what we know so far. So next slide, please. Just to give you an overview, in general, the way immunization practices or guidelines in the United States are set up is that the CDC has an advisory council on immunization practices, that's ACIP. So they're the ones that periodically go over the research, go over the data, decide what the recommendations are nationally, and the CDC officially approves that. And then that gets formally published in the MMWR, so Morbidity or Mortality Weekly Review, that comes out of the CDC. And that's, at that point, is when we as providers and clinical staff go ahead and put that into practice. Well, just last month, ACIP recommended a revision to their HPV vaccination recommendations. The CDC has approved it, and they are furiously writing to get it published, these new recommendations published in the MMWR. We anticipate this month or next month, so before the end of the year. But really the goal is getting this new recommendation in practice. And for us as a collaborative, it also meant us having to rethink a little bit about data collection and so forth, which is why Sam was mentioning we've had to make a few changes there. Next slide, please. So just as a reminder, there's a few HPV vaccines out there, and they've been out there for a while. So we started out with an HPV vaccine that just covered 2 serotypes. It was soon followed by one that covered 4 serotypes, or the HPV4 or Gardasil. And then we now have a 9 serotype HPV. So there's over 100 serotypes of HPV, but 9, the ones most commonly associated with cervical cancers and oropharyngeal cancers and genital warts, are covered in the current 9-valent. And if you can do a few flips, Melanie, please, 'cause there's going to be some animation here. As of basically this month, one more, Melanie, it's really only the 9-valent that's going to be available in the United States. So if you can do one more click, Melanie, please. The 2-valent HPV vaccine, Cervarix, otherwise known as Cervarix, and the 4-valent HPV vaccine, otherwise known as sort of the traditional Gardasil, are still being produced by GSK and Merck, but they're only available, will only be available overseas. As of, like I said, this month, and certainly by the end of this year, only the 9-valent will be sold here in the United States, which, though, has the most HPV coverage for us. So, and has been really the vaccine being used in clinical practice now for many years. So it's probably the ones most of you have stocked in your own refrigerators in the clinic as part of your HPV vaccines. Next slide, please. So the previous recommendations that we have been working off of and that some of you guys have mentioned is this 3-dose series. You know, all of 11 to 12-year-olds, males or females, routine recommendation across the board for all of those 11 to 12-year-olds that they receive 3 doses of HPV vaccine. It's the first dose at time 0, so for instance today, a second dose 1 to 2 months later, and a third and final dose 4 months after that. So all together it takes about 6 months if everything was like right on track for that full 3-dose vaccination. Next slide, please. With the new recommendations, and I'm going to talk about in a moment specifically what that 2-dose schedule is, there are also, however, some things in terms of the recommendations that we have already been working on that's still relevant and appropriate, and the CDC is still making that part of the recommendations. So what hasn't changed is that we're still talking about an FDA-approved vaccine, HPV vaccine, that's FDA-approved for 9 to 26-year-old, again, males and females, though the recommendation is to start that vaccination series at 11 to 12 years old. There are no contraindications to the vaccine except a severe allergic reaction to a previous HPV vaccine. You don't, or a patient does not need to restart the series if they're late on that second dose or that third dose. So even though we have an ideal schedule of that, you know, a few months later getting the second dose, a few months after that the 4th dose, if it's a year between dose 1 and dose 2, that's okay. You don't need to restart the series. You just pick up where you left off. And what's also still true, though may not be as clinically relevant to us here in the next few months, is no matter what vaccine you started with, so whether a patient's first dose was using one of those 2-valent HPV vaccines or 4-valent, or if they started right off the bat with the 9-valent HPV vaccine, you can always switch midway through a series and finish off your vaccine series with HPV-9. There also currently are no recommendations for patients to redo a whole series just because they didn't do it with the 9-valent to begin with. So some patients may be saying, well, I only got the 4-valent HPV vaccine. I'm not covered for all the other ones that would have been in the 9-valent. And that's true, but there's currently no recommendations that state that we should be revaccinating them all over with the 9-valent. They're still getting very strong coverage against cervical and oropharyngeal cancer and genital warts. There's also, and again, this is some part of that strong provider recommendation, but recognizing and emphasizing the importance that this vaccination is recommended preferably when before they're sexually active, but certainly sexual activity doesn't negate the fact that this is still a really important vaccine, nor is having a previous HPV disease, genital warts, an abnormal pap smear showing HPV abnormality, or oropharyngeal biopsy that showed HPV. Those all are suggestive that someone has already been in contact with the infection, but again, remember, we're covering multiple serotypes, multiple strains of this virus with the HPV vaccine. So getting them vaccinated just allows us to protect them from other strains that they may not have already acquired. So ideally, though, before sexual activity is best because that gets their body primed and ready to fight off the infection long before they ever come across it, hence the 11 to 12-year-old recommendation. And Dr. Feimster in a few minutes is going to do a really nice, much broader overview of HPV in general, but part of what she'll be emphasizing is the strong track record of proven efficacy for the HPV vaccine. We've seen this both nationally and internationally now as the HPV vaccine has been implemented, showing marked reduction in cervical cancers, in oropharyngeal or oral cancers, in anal genital disease, and genital warts. So a very strong and potent cancer prevention tool for providers. Next slide, please. But luckily for us, part of what the CDC was able to review is the fact that since the initial HPV recommendations, some of the post hoc analysis and studies have now led them to be able to revise what the recommendations are because of the evidence coming out of it. So next slide, please. So the new recommendation, or I should say the new addition to the recommendation, is that if you have a patient who is less than 15 years old at the time of their very first dose, then all they need is 2 doses. And that 2-dose series is ideally dose 1 now, for instance, as long as they're under 15, and that second dose either 6 or 12 months later, though a minimum of 5 months is what's being stated as the minimum time period between those. So again, if they're younger than 15 at the time of their first dose, whether you're giving them their first dose today or whether you're seeing a 17-year-old in your clinic, but when you look at their records, their first vaccine for HPV was when they were under 15, then they can be eligible for a 2-dose series, and I think potentially help some of you who have been struggling with that repeat those second and third doses. You may be able to find that you can reduce that log of patients given that they may be eligible for just 2 doses to get it over with. Next slide, please. The reason why, well, part of the reason why we can even make these recommendations is because the way the vaccine works. So whether we're talking about the 3-dose or the 2-dose schedule, really what the vaccine is doing is that first dose or those first 2 doses for the 3-dose one are really priming the immune system to get it going against HPV. And then it takes a few months for the memory B cells of the immune system to mature and differentiate so that they're really going to be active should they ever come across an HPV strain. So that's why the boost has to happen a minimum of a certain amount of time after those first prime doses so that they get that adequate maturation. So even with the 2-dose schedule, as long as we're giving it, that's why we do that boost at the 6 months after the prime so that we can get that good, adequate, long-term response. Next slide, please. So I'm just going to be doing some very high-level summary stuff of all the research and data that went into the CDC's updated recommendations, but just know, excuse me, that some of this data is One is that they've seen strong, persistent titer responses or antibody titer responses over the long haul for patients that have received the HPV vaccine. So the longest study to date is now out almost 10 years since that patient has been vaccinated, or that group of patients has been vaccinated, and they have shown long-term strong antibodies still even 10 years out now. There's also been strong evidence showing one of those statements that I know you guys were answering or giving your response to as part of the provider survey, and that is the immune response seems more robust in younger adolescents. They have a higher antibody titer when receiving the vaccine compared to older adolescents, and that sort of cutoff point is in the younger group, and by that we mean kind of 10 to 14, so that you can already see a little bit of why that 15-year-old cutoff is part of the new recommendations. Next slide, please. What the CDC was also able to review, though, are studies specifically done that looked at this question of can we as a population do a 2-dose series and be just as effective as a 3-dose series. So and these are just examples of some of those studies that the CDC reviewed, and I'm not anticipating you being able to read all these little numbers, but what you will hopefully be able to see are these graphs look really similar, right? So what this is showing and comparing is younger adolescents, again, that 9 to 14-year-old range, and what their antibody response was after vaccination and then following it over time. And you can see the two top lines, the red and what looks like the dark blue being those younger girls that got 2 doses of HPV, the red line being, again, younger girls but who got 3 doses of vaccine, and the green line just below is older girls, or that 15 and higher group, who receive 3 doses, and that is sort of the gold standard control group in a way, because that's kind of how we've been practicing all this time. But the point is, whether these younger girls got the 3-dose or the 2-dose series, they were able to not only have as good of an antibody response, but frankly, slightly higher. And similar sort of story that you can see in the lower graph as well. So that not only is prompting the CDC's recommendation for these 2-dose series for the younger adolescents, but it's also why last month the FDA also approved that the HPV-9 vaccine be approved, be licensed to do 2 doses for those younger 9 to 14-year-old males or females. Next slide, please. Things to keep in mind with these new recommendations is that actually this is not new. So since 2014, the WHO and the European Medicine Agency has already been recommending a 2-dose series for what they were using HPV-2 and HPV-4. Again, younger population, just like our U.S. CDC recommendations are now stating. But we've already seen this start to be put into practice overseas. We should also keep in mind that so far, since this obviously is a new recommendation, there's no randomized control trials looking at the 2-dose HPV vaccine effectiveness against sort of clinical endpoints. So all of those studies and research I was describing that shows us how effective it is against cervical cancer and oropharyngeal cancer and genital warts. Well, those studies just haven't been done yet with the 2 doses, but certainly some of the post hoc analysis from just having older studies where girls and guys did not, for instance, fully complete their series, and so by default ended up kind of being like a 2-dose, suggests that they have very similar efficacy whether a patient is receiving 2 doses or 3 doses, particularly in these younger patients. And there's also, just to remind ourselves, no long-term titer response studies yet for this 2-dose vaccine. So as I was mentioning, studies that have shown now 10 years out that these patients still have very strong, robust immune responses to HPV. Well, we just don't have that data yet for 2 doses series, but we do have the knowledge of the 3-dose response and the recognition of the antibody kinetics and how the immune system responds to these vaccinations. And we there certainly suggest a very similar long-term titer response. Next slide, please. So again, just as a reminder, if your patient was under 15, so before their 15th birthday at the time of their first dose, they would be eligible for a 2-dose series. And in order to get that 2-dose series, it's the first dose at time 0 and the second dose 6 or 12 months later, but at least a minimum of 5 months to give that immune system a time to mature. And once they've gotten that 2 doses, they're considered adequately immunized. Next slide, please. The 3-dose series, though, hasn't left us. So we still are going to have patients within our population that need that 3-dose schedule, and they include patients who were 15 or older at the time of their first dose, whether it's you're seeing them today to start their series and they're already 15, or whether just looking back in the records, their first dose happened when after they had already turned 15. They'll still need the typical 3-dose series that we're already accustomed to giving as part of our HPV recommendations. You'll also still need to do 3 doses for patients who are immunocompromised in a way that affects their immune system, humoral immunity and cell-mediated immunity. So it's not every single immune system deficit, but again, the CDC's language will have has very specific rules in and rules out. But in general, think about those immunocompromised patients needing 3 doses because we want to make sure they get a really adequate immune response to the vaccine. And just keep in mind, you may have patients that were younger than 15 for that first dose. Great. You would think they need just two. But if they happen to have already gotten their second dose and that dose was actually on time, so maybe it was a month or 2 later, like is typical for the HPV recommendation, then they just haven't had enough time between that initial prime dose and that boost dose that they're going to need. So you're going to have to wait or determine when they at least kind of pass that 5-month cutoff mark, and then they can do that last dose. But technically, they've gotten 3 of them along the way. Next slide, please. If you're interested or if the providers in your practices are interested as well, this is a link to the formal webinar that the CDC gave last month about this updated recommendation. And like I said, we expect the MMWR publication to come out momentarily. And I want to thank Dr. Markowitz, who gave that CDC presentation, because I've stolen some of her graphs from it. So thanks.